Okay, so this section's on plantar fasciitis. And we can start with anatomy. We can see in the picture on the left here, the skin and fat's been removed, and we can see the plantar fascia extending from the calcaneus across the metatarsal heads to the phalanges, right? And so the medial border's kind of marked right here, and then we can kind of see on the medial side the origin of the plantar fascia arising and running distally. And we can kind of note that really plantar fascia abnormalities on imaging are really found here at this proximal section of the plantar fascia. We can also look over here on the right on the MRI, note the tibia, the talus, and the calcaneus. We see the Achilles tendon running distally, and then it kind of merges with the periosteum. And people see it as there's somewhat continuous with the plantar fascia, which is right here, running in this kind of dark black line between the fat and the flexor digitorum brevis and the plantaris quadratus plantae muscles. Then we look at the imaging. This is a normal imaging of a plantar fascia. Here's the outline on ultrasound. This is the outline of the calcaneus here. This is the flexor digitorum brevis here, and then we can kind of see the outline of the plantar fascia just superficial to the muscles. And then this is fat. Okay, so here's another image, and I'll give you a second to orient yourself. Find the calcaneus shadow. Find some of the muscles. Go ahead and try to see if you can find the outline for the Achilles or the plantar fascia. And then if you identify these borders, then you were correct. So those were normal images. Now these are abnormal images, and you can immediately see that there's thickening of the plantar fascia here. Here's the calcaneus. These are the musculature, and this is fat up here. So that's definitely a thickened tendon. And then here we have like a enlarged or nodular kind of tendon, and this is the normal kind of thickness of the plantar fascia over here. This is the calcaneus here. So strong abnormalities on ultrasound imaging are possible, but the presence of an abnormality doesn't guarantee the presence of pain. There's plenty of people that have asymptomatic nodules and thickening. Okay, so how severe is the pain? So for these patients, this is a study that I did a year or so ago with Dr. Neville from SUNY. And what you can kind of see, we sampled pre-post PROMIS scores on 300 individuals that had foot and ankle problems. And here's all the different kinds of foot and ankle problems. This is their initial PROMIS score on the pain interference measure. And then this is their follow-up. And then this is how many patients reached a patient acceptable symptom state or PASS at completion. And what we can kind of remember here is that PROMIS of 50 is the U.S. average, and then a 10 is a standard deviation worse. So basically a 60 here would be a standard deviation worse. So we can say ankle sprains at 60, just general foot pain was the highest, 61. But post-surgical pain is 57. Fractures were 58.8 at post-surgical. And then plantar fascia kind of fell at the really high level. So 59.8 comparable to the highest level of foot pain problems. And then we can see pre-post, they really didn't do that well. And so this is going to, cause some discussion as we go through this kind of talk here. But there were only 14 patients in that sample. So essentially, with that kind of background, we can kind of start to talk about differential diagnosis and how these patients present. Essentially, onset's gradual. It's usually associated with a lot of standing in terms of risk factor, especially on hard surfaces, and then restricted dorsiflexion range of motion is a key risk factor for acquiring plantar fasciitis. It's characterized by pain with the first step in the morning. A Silva Gold test is something that the surgeons use a lot. And that this is another example of a self-report that's quite low in patients with plantar fasciitis. So essentially, the pain's coming on pretty quickly. They don't really understand what they did that caused it, and it has a disturbing nature to it. So they really need kind of our help and guidance in understanding what the course of action is for them. And what you should know and write down here, because I didn't put it in the slide, is that plantar fascia is really a self-limiting disease. So essentially, patients have the pain. It seems kind of severe, but then it runs its course in a period of about 9 months. And all but about 20% of them at that point will have relief of symptoms. And so this is qualitative data on what's, patients are thinking about when they start to have plantar fasciitis, and what they kind of relay in qualitative interviews. And you kind of see some of their comments here on the right. Some of them are very anatomically focused. They talk about heel spurs and arthritis, the cause of it with long shifts and kind of standing on their feet, excessive loads, things like that. And then you can also see, very descriptive words used for what's happening in their foot, like it's tearing, right? And that gets to do with what it feels like and the nature of the pain, not just the intensity. And then some other kind of words, qualitative words here that they use to think about their plantar fasciitis problem. And so, our help in terms of framing this and understanding what it is can be quite powerful. This is from the 2014 Heel Pain Guideline, and you can kind of see these different elements are the key to your differential diagnosis and assessment. So what you're looking for is medial side plantar heel pain, and it's this history that you kind of see there, these first steps that are really pathoanatomic for distinguishing plantar fasciitis. And then heel pain precipitated by an increase in weight-bearing activity. So a lot of times they had a long walk or something at work that they were on their feet longer that kind of initiated it. Reproduction of the pain with palpation, and that's on that medial calcaneal tubercle that we've already gone over, a positive windlass test. And then you want a negative tarsal tunnel test, and this is basically tapping the tarsal tunnel on the medial side of the foot with a kind of Tennell sign test, and that should cause no reproduction of symptoms in the heel. And then negative test for referral to the heel, and then pretty much then you're affirmed that it's plantar fasciitis. Now, luckily, this is a grade A on that previous guideline and continues to be a mainstay of treatment. Is this dorsiflexion of the ankle with dorsiflexion of the first metatarsal head usually pops out the plantar fascia, and you can kind of see it right here. In this stretch, when it's done prior to weight bearing, after resting a long time, so that first getting up in the morning or sitting in class for a long time or sitting at a desk for a long time, and then you do this before you get up, you can alleviate that pain and sometimes eliminate it. And then the relevance of ankle dorsiflexion is supported by evidence that the gastroc soleus stretching also helps patients with plantar fasciitis. The Silva-Skull test is shown here. It's a way of defining the restriction that's associated with the gastroc muscle itself. So essentially you measure the knee in extension, and they're showing here there's 0 degrees of dorsiflexion, and then you let the knee bend. And when you let the knee bend, in this case, they're measuring increased dorsiflexion by 20 degrees, so quite a difference, meaning that most of this dorsiflexion restriction is due to the gastroc. Now, another grade A treatment is a strong support for people who really are having a hard time weight bearing and need to weight bear. And so essentially foot orthotics or foot support, like both taping and orthotics, have strong evidence that they can relieve pain and help people function. So on the left, we have an example of somebody making a custom orthotic that actually accentuates the arch, and they wear this just for a few days and then wean off of it. And you kind of see that outlined here. And then on the right, we can see a taping technique, which is called a Lodi technique, which is being used that's supporting the arch. And the idea is you're accentuating the arch so that you can protect it. And nowadays, the taping techniques, instead of just using elastic tape, you can use kind of this, our old style tape, you can use new elastic tapes that stay on a little longer and give extra support. So here's an example of comparing both the orthotics and the stretching to an injection. So I had 2 different groups, and we kind of see the outcome of that. And essentially they gave them orthotics and the stretchings and then followed them over a 12-week period. And they compared that to an injection. what we can kind of see is this is a foot scale where higher scores are better function, and I think what's remarkable on this again is like just how low the scores are at the beginning. Again, emphasizing how, plantar fasciitis, although we see it's a tendinopathy kind of thing, or a tendinosis of the plantar fascia. It doesn't seem that severe, yet it seems fairly disabling when we look at self-reports from patients, and that's what we're seeing again here in this particular graph. And so essentially the other thing we see is the orthotic and stretching is equivalent to an injection. And essentially the other thing that's important is that even though both groups improve at 12 weeks, which is four months, they still don't have a perfect function. So they have some lingering symptoms, and this is that idea that long term the prognosis needs to run about 9 months before they really get back to zero. And so here we see the stretching and manual therapy kind of together. What's happening there. Early on there was some evidence for this in 2009 that manual therapy might be helpful. And since then, there's been other studies done, and really there's really no strong support for manual therapy in addition to stretching. It's really just more of kind of stretching is good, right? And here's a recent study that kind of does also compare that, and here they're adding a couple different manual therapy techniques. Mobilization, manipulation is this blue group here, and then you have mobilization, manipulation, and this cross-friction massage. So it's a massage across the proximal part of that tendon to try to cause remodeling. And then you have the second group, the green, or the maroon. What is that color? Dark red, I guess. And you have stretching of gastroc complex with the cross-friction massage, it's just stretching. And then the green here is all three therapies together. So essentially they weren't really statistically significant. You can kind of see this is that natural history pattern that we had just talked about. Essentially you have you start with kind of fairly severe symptoms, then you have this kind of gradual improvement irrespective of which group you're in, essentially. So now we're going to move to looking at strength. And so when you have like this particular slide, I'm trying to show other tests than what you already know in terms of manual muscle tests for like the ankle, posterior tib, peroneal muscles, flexor hallucis longus, and flexor digitorum muscles. So you already know how to do all of that. And so this is in addition to those tests. What you might look at is a paper pull test, which is kind of a functional test with an external reference for the person to hold a piece of paper with their toes down onto the floor so that you can't pull it out. And this is nice tests because the patients can really relate to this. The idea that they can't hold a piece of paper or post a piece of paper on the floor, for many resonates for them. They kind of think about why they can't do that, and it can motivate them to try to do activities that help them succeed at that test. And this is kind of a clever test. I don't know that I've used it that much, but it's useful to think about in terms of heel rise. We tend to think of a heel rise test as something that combines challenging the midfoot and also challenging the calf, and putting the foot on a rocker. What this does is eliminate the challenge of this for the foot specifically, but then isolates the challenge to the calf. So if this relieves the symptoms for someone, that also indicates that the challenge, that the foot function is what's limiting their ability to heel rise. So nice, interesting assessments, kind of clever, and this kind of falls in that same category. A few years back, this man Rathcliffe came up with this idea of, well, if eccentrics are good for tendinosis at the Achilles, maybe they'll also be helpful for the tendinosis at the plantar fascia. And so he's trying to figure out how to stretch it. And so what he thought was maybe we could do heel rises with the first metatarsal and dorsiflexion, which would then recruit the plantar fascia. And you can kind of see in this picture, the plantar fascia is just kind of popping out a little bit right there. So the idea is you cock up the the first metatarsal phalangeal joint into dorsiflexion as they do the heel rises, and see if that kind of helps the patients at some level. And then they had this outcome. So here's the foot function index again. So lower scores on this are better. And then they compared a shoe insert and stretching, so just kind of the same thing we saw with the injection treatment. And then this was the shoe insert and strength training, so then they just did the strength training instead. And what you can kind of see is you have this really big effect at 3 months, where essentially the strength training, which is here the gray, it does much better than just the stretching at 3 months, and then it pretty much plateaus. So it does seem to accelerate that initial recovery period, but then again, you end up with this kind of lingering kind of symptoms that aren't so bad, but they're still there even at 12 months, because notice it does not go to zero. So finally, you can also just do, if there's strong impairments across the foot, you can also just do a more general kind of exercise program, and we've already covered this for the posterior tib, where we do heel rises, toe movements like spreading and toe curls, and then the doing exercises that you saw previously. And then you can also work on footwear, and footwear I think got a B or maybe even a C in terms of adjusting or influencing plantar fasciitis. But in essence, what I put this in because I wanted people to think about this, and essentially in that study that we talked about before, just walking barefoot was enough to kind of activate the intrinsic and extrinsic foot muscles. And I think they're making a good point here, where essentially if you wear minimalist shoe wear compared to full shoe wear, you get these kind of larger increases in the muscle PCSA across the foot intrinsic muscles. And this one right here was showing the flexor digitorum brevis, which has a much larger increase in muscle cross-sectional area when you're wearing like a minimalist shoes, and that's for both of these categories. So if strength is an issue, walking barefoot or wearing shoes that with less support can be helpful in kind of reinforcing the arch. And then I wanted to kind of show this again. This is our same exercise program that we showed you before, and this is one of the remarkable outcomes that occurred. And essentially, we never did anything with heel rises during this exercise program. There was absolutely no training related to that, just these 3 exercises. And this is the pre-post change in their heel rise ability on the left and right. And you can kind of notice that even though we didn't train the heel rise at all, we saw an increase in reps of like 5 to 10 reps that was statistically significant. So just more affirmation that training the foot actually can help function proximally at the ankle. So finally, that we have did a pretty good job setting up the psychosocial part of the pain experience that these individuals are having when they first start experiencing plantar fasciitis. It's very disruptive, and it's partly because of the severity and then the nature of the symptoms. And so, a biopsychosocial approach may be effective here. And there is no clinical trials that I found, but it seems like there should be some coming soon. And this particular piece of evidence that you're seeing here is showing that basically pain catastrophizing is higher in patients with plantar fasciitis, and that it correlates to important patient-reported outcome measures. So essentially, watch out for pain catastrophizing. It's going to be a part of the profile of these patients, and using kind of the normal skills we would and have learned for other problems would apply. So there's a whole bunch of treatments that are recommended in the 2014 guideline, and here are some of them in the grades. The one I didn't include that also gets an A is a night splint, but I'll let you look that up. And then these other ones that are still kind of not on the fringe, really. So that's it. Thank you.